Hello everyone. So let's get back to our discussion. Next question is a 47-year-old patient complains of insomnia, heaviness over his entire body, constantly depressed mood. He considered himself good for nothing. Good for nothing. Inadequate. He considered himself, okay? Believes that he is a burden to the family. Wants to die. So, sure shot, it's a case of depression. It's a case of depression. Okay. Hypomipes with sorrowful expression. Okay. These are all classical signs of depression. Okay. So we have some answer here. What is schizophrenia? Schizophrenia is in schizophrenia we have delusion, hallucination. We don't have nothing in this question like this. Okay, disorganized speech. And we have non-specific like apathy, then anhedonia. Okay. In Alzheimer's, it is dementia. Okay. So we have memory loss here. In Alzheimer's disease, we will have memory loss. Okay. So we left with what is atherosclerotic depression? It is depression which cause atherosclerosis. Okay, so this is not our answer. Alzheimer, memory loss, nothing. Not our answer. Schizophrenia, nothing. No delusion, no hallucination. Okay, so we got two depression. One is neurotic and second was major depressive disorder. So what is major depressive disorder? It affects your happiness. Happiness. Okay, mood. Okay, and neurotic, it should be like a low mood for more than 2 years. Okay, and two other symptoms. Two other symptoms. So as we see, like he considers himself good for nothing, inadequate, burden to the family, wants to die, sorrowful expression. So it affects his happiness, and this is our major depressive disorder. Next one is a patient aged 16 complains of headache mainly in the frontal and temporal region. Okay, headache mainly in frontal and temporal areas. Superciliary arc appearing or vomiting at the peak of headache, pain during the eyeball movement. Okay, then joint pains. On examination, excited, temperature is high, pulse tonic and clonic cramps. So we have focal symptoms, right? Uncertain meningeal signs we have also. Okay. So what we have? We have ear influenza, RSV, parainfluenza, adeno. We should learn about these things. What we get in influenza. Influenza. And what we get in parainfluenza. You know, like adenovirus, it will give you GI symptoms. Okay, RSV, it's common cold. You will have sinusitis. Okay, it's common cold. Then you have influenza, parainfluenza. So it is abrupt onset. Abrupt onset. It's gradual. Gradual. Then it is mainly upper respiratory tract infection. It can involve lungs. Okay, and here we can have cerebral signs positive. Okay, so we have cerebral sign positive. Here we have meningeal signs. Okay, and it is abrupt onset. Okay, no gradual things and no involvement of lungs. So it is influenza, not parainfluenza, but not a typical type. It is a cerebral edema manifestation. We have cerebral edema. That's why we have the patient is having pain during the eyeball movement. Okay, you know, if cerebral edema, this will increase the intracranial pressure, and that will lead to papilledema. Okay, right? And also vomiting. These are signs of ICP. Okay. The next question. A 64-year-old patient has developed squaring substernal pain, which has appeared 2 hours ago and irritated to the left shoulder. Marked weakness on examination, pale skin, cold, pulse 108, arterial pressure 750 by 50. Heart sound are deep, vesicular breathing, soft abdomen, painless, varicose vein on the left shin, ECG sinus rhythm, heart rate 100, ST segment is sharply elevated. In 2-3 heavy bleeds, what is the most likely disorder? So here the sure short diagnosis is, what is your diagnosis, right? So ST segment is sharply elevated, so it is our ST elevated MI. Okay, because we had substernal pain radiating to the shoulder. Okay, after 2 hours, appeared 2 hours ago. Okay, and the ST segment is sharply elevated, but in which leads 2-3 AVF, that is our inferior leads. If you want to learn about the leads, like which MI, which lead, I will make a separate video. So 2-3 AVF, it's inferior STEMI. Okay, and we have a low BP that gives us a shock. So then we have also shock. What causes this shock? So this STEMI means myocardial infarction. Infarction means damage or dying of the myocardium that leads to like decreased functioning of the heart, and if the heart function get decreased, we can have decreased cardiac output that can lead to shock. Okay, and this shock is called cardiogenic shock. What is cardiac asthma? Cardiac asthma means if we exclude all the pulmonary causes and then we have dyspnea, this is called cardiac asthma. So nothing like this here. Pulmonary artery thromboembolism. What is pulmonary artery thromboembolism? We will have sudden breathlessness. Okay, after any history of any long bone fracture or DVT, so nothing like that. Then aortic aneurysm, as we said before, it gives tearing pain. Okay, tearing pain. Cardiac tamponade, we had we have a triad. Okay, the triad is called Bextrade, and the three components are hypotension. The three components are hypotension, increased JVP like jugular venous pressure, okay, and muffled heart sound. Muffled heart sound. So we have hypotension here, but not any JVP increase or muffled heart sound. So this is not our answer also. So cardiogenic shock. But you know what? You need to learn about the types of shocks and how to differentiate. So this cardiogenic shock is post inferior STEMI. Okay, so now short discussion about shock. So we have our hypovolemia. Let me keep some space here. Okay, so we have our hypovolemic shock. We have our cardiogenic. Okay, then we have our distributive, and in this distributive we have the sepsis and anaphylaxis one. Okay, and the obstructive. Okay, so now in hypovolemia we have history of bleeding. Okay, history of bleeding. In cardiogenic we have history of heart disease. Okay, then in distributed we will have sepsis or anaphylaxis. Okay, in obstruction we can have any tumor or malignancy, or we can have DVT, right? Then what about JVP? In hypovolemic shock, okay, the JVP get decreased because there is low volume. In distributive shock, the vessels get extended or dilated, so JVP. In obstructive too, the JVP doesn't affect, it can be normal or low. But in cardiogenic, what happened? In cardiogenic, the left ventricle fails to push the blood through our, so left ventricular pressure increase, then the right ventricular pressure increase, then to pulmonary circulation the pressure increase, then to right ventricle, then to right atrium. So left ventricle, left atrium, then pulmonary, then right ventricle, then right atrium, and then to the JPP the pressure increase. Okay, so backward pressure flow. Okay, so stand out here. Then temperature of extremities we can see, like in hypovolemia we have cold, in cardiogenic we have cold extremities, in obstructive we will have cold. Usually if there is no blood, so the extremities will get cold, but in sepsis we will have warm extremities. Okay, what about cardiac output? Output decreases in hypovolemia, decreases in cardiogenic, then increases in distributive. That's why we get warm extremities, and normal or decrease in obstructive. Okay, or there is one more neurogenic also. Okay, then about heart rate, so it increases here, it increases here, and it increases here too. Okay, so these are the classification of shock we need to remember. So as we say, our cardiogenic shock, we have a history of heart disease like MI, injury, then JPP should be increased too. So they didn't give here. Okay, so next one is a 28-year-old patient complains of periodic compressing heart pain, periodic compression heart pain. Okay, so periodic sorry periodic compression heart pain. Brother died at age 34 from cardiac disease with similar symptoms. So family history. Objectively, the patient's skin is pale, heart border displayed no significant deviation, heart sound are loud, there is a systolic murmur. Okay, murmur we will study later. Okay, after all the points with a peak above the aorta, so peak above aorta, systolic murmur, this indicates us that we have a problem with aortic valve. Okay, echocardiography reveals thickening of the interventricular septum, thickening of the IV septum in the basal parts, reduction of left ventricular cavity, reduction of left ventricular cavity. So what is our diagnosis here? So we have a history of heart disease, then we have compressing chest pain, then we have a problem in aortic valve, and then we have the thickening of interventricular septum and the reduction of left ventricular cavity. So this is a case of hypertrophic obstructive cardiomyopathy, and specifically if you say it is idiopathic hypertrophic hypertrophic subaortic stenosis. So as the basal part of the interventricular septum, so this is, if this is our interventricular septum, here we have our aortic valve, right? Here, so if this part gets thickened in the basal portion, so what happened, the aortic valve gets stenosed, okay, and this stenosis of aortic valve or aortic stenosis gives a systolic murmur. Why? What is murmur? Murmur is the abnormal flow of blood, okay, towards or from the heart. So in systolic murmur means we have the abnormal flow while systolic, okay. So in systolic what happened, the heart pumps, and when the heart pumps, the aortic valve opens, and so we are getting this systolic murmur when the aortic valve opens, okay. So if the aortic valve is stenosed, means it is not opening easily, so it will give us a abnormal flow of the blood. So this is the systolic murmur. We will discuss the murmur later, okay. So what happens in HOCM? Okay, we don't have any specific treatment for this disease. Okay, cardiomyopathy we cannot treat specifically. We can slow the progress, right? So how do we slow the progress? We have two set of drugs. Okay, we have some new drugs to increase the ejection fraction now. We will discuss later as these are more clinical, towards clinical. So we have two sets of drugs. Okay, we have two sets. Okay, so for HOCM, we have two sets of drugs which will slow the progression. First one is beta blockers, okay, and second one is prils like angiotensin receptor, angiotensin converting enzymes inhibitor, okay. So we have two, like the prils one and the lols one, okay. So furosemide, nitroglycerin, digoxin are not our answer. So we have like the beta blockers and the ACs both, okay. So we should prescribe both, but this one is specific to control the heart rates, okay. So when you will go to clinicals, these things are not like this, like you have to use it first or second, you give it both, but for question purpose you need to know that metoprolol beta blocker is the first line, okay, first one, okay. Then a patient aged 40 has been ill during approximately 8 years, complains pain in the lumbar part of spine, physical exhaustion, age 40, cervical and thoracic, especially when coughing, pain in the hip and knee joint. On examination, the body is fixed in the forward inclination with head down, gluteal muscle atrophy, spine, X-ray, ribs, osteoporosis, longitudinal ligament ossification, most probably diagnosis. So I think I have said it before, a young adult, okay. Then lumbar part of spine, and then what is called forward inclination, this is called hyperkyphosis, okay. So these three things, lumbar involvement, hyperkyphosis, young adult, okay, this is a classical sign for ankylosing spondylitis, and remember it is associated with HLA-B27 antigen. Okay, psoriatic, you will have a skin involvement too. Okay, so we don't have this here. What about skin involvement, skin nails involvement in Retter's disease? It is reactive arthritis, so it's asymmetric arthritis. Okay, then urethritis can happen also. Okay, and spread osteochondrosis of the vertebral column, it is no. And tuberculosis spondylitis, no history of tuberculosis, nothing symptoms like night sweats or weight loss, nothing like this. Okay, so these things, remember these signs, and the answer is sure shot ankylosing spondylitis. Okay, then a 38-year-old man is working for 15 years on slate producing factory. He complained of aspiration, dyspnea, or exhaustion, dry on physical examination, dullness of the percutatory sound in the interscapular area, harsh respiration, dry diffuse rails. There are spots of grayish color of the hand, color, grayish color on the hands. Okay, the doctor planned suspect asbestos, so they have given the diagnosis. What method of confirmation? So for asbestosis, what we do? Asbestosis first, any pneumoconiosis, will do a chest X-ray first, and second one is if you want definitive diagnosis, then biopsy. So it's an invasive procedure. We don't do it in the first hand. So chest X-ray is the most common. Okay, chest X-ray. We will not get anything here. I think same question. Asbestosis, chest X-ray. Then 37-year-old woman is suffering from squeezing substernal pain. So on physical exertion, what is this called? I have told you before, this is called classical angina, right? Angina. On examination, arterial pressure 130 by 80, heart rate 72, heart bars are dilated to the left side, aortic systolic murmur, ECG signs of left ventricular hypertrophy. What method of examination is the most informative in this case? Okay. So we have a left ventricular hypertrophy, right? And so any heart disease, what we will do first ECG. Any patient comes you with any heart problem, we will do first ECG, and second one is echo. These are the gold standard things. ECG, it is for the electrical portion of the heart. Okay, electrical portion of the heart, we will check the electrical situation of the heart, and in echo we will get the functional one, the structural one. Okay, so in ECG we will get the electrical, and in echo we will get the functional. So in ECG you have some signs of left ventricular hypertrophy, so like you will get tall or waves, okay, amplitudes or waves, and then to see the hypertrophied heart, and to check the important thing, which is our ejection fraction, we have to do an echo. So then next procedure is echo. Like coronography, X-ray is not our thing. Phonocardiography is not used these days. Like mainly, this is not also coronography we can do, but first we need to do these two things. After that, we will see what we can do. Okay. Any invasive procedure we will do in second line. Okay. And then a 58-year-old patient complaints of osteoarthritis. So like let's get back to here. What we can suspect: ventricular hypertrophy, aortic systolic murmur. We can suspect here HOCM2, right? Hepatic cardiomyopathy. So a 58-year-old woman complains of osteoarthritis of knee joint for 2 weeks. She had been receiving an inpatient medical treatment. She was discharged from the hospital in satisfactory condition with complaints of minor pain after prolonged static work. So this is not a warning sign, okay? Not a warning sign. Local hyperemia and exudative effect in the area of joints are absent, okay? So no local hyperemia, no inflammation, okay? So what further tactics most well? So we said we can treat it in outpatient, okay? If if the patient has no uh, red flags, we can treat it in outpatient. Interesting question. Next one. A 42-year-old applied to hospital with complaints of pain behind the sternum with irradiation to scapula. What we have? We have pain behind the sternum. Sorry. Pain behind the sternum with irradiation to the left scapula. The pain appeared during significant physical work. This lasts for 5 to 10 minutes over. On rest, the patient is sick for 3 weeks. So, first the diagnosis. What is the diagnosis? The diagnosis should be angina. Which one? As it is appears only during significant physical work, so it is stable. So it is stable angina. The diagnosis is stable angina. Okay. Now the main thing is they have given the classification. So first one, there is one that is variant angina pectoris or prinzmetal. As I said before in my video, prinzmetal is not due to mainly plaque, it is due to vasospasm. Okay, so it doesn't care if you are working or not or resting, it can affect you both ways. So this is not our answer. Okay, so now what we'll do, we'll learn a little bit about the classification of angina. So here is our angina pectoris. Okay, the stable one obviously, and we have some classes. You need to remember this for exam and for clinical too, because according to the class you treat the patient. So we have four classes. Okay, so the first one, it is what? It is the lowest one, lowest grade. It is pain only after very strenuous or prolonged exercise. Exercise. Okay. In fourth, you have rest pain. So these two are in between. Okay. Class 3 is you have pain in everyday. So in class 2, what? It is slight limitation. Okay. Then class 1. Okay. Then class 1. So what do you see? You see the pain appears during significant physical work. This lasts for 5 to 10 minutes over rest. So class 4 no, progressive? No. You have stable angina pectoris of effort 1. Yes, it is class 1. And we have a first stabilization. So these answers are so much confusing. Okay, I think you won't get something like this. So either you get this or this. So this is the first time they are establishing. So this is the first established angina pectoris, and also the type 1 or grade 1, you can say. Then patient feels sick 16 hours after dried fish intake. There was nausea, vomiting, weakness, flaviness, double vision. On physical examination, there was decrease of a muscle tone, anisocoria, flaccid swelling, and tendon reflex. So we have something in some intoxication. What we are seeing? We are seeing decreased muscle tone. Okay, so it is not about food intoxication, not gastritis, no symptom of gastritis, no symptom of uh, focal thing, so no encephalitis, no symptom of focal, no focal neurological sign. And salmonella we also get gastric problems. Okay, so we have botulism. Remember that in botulism you will have always a history of dry fish, dry fish, or you can say fish or canned fish, these things. Okay, or canned food can also be canned food. Okay, so these things and this botulism, how it's work? It works by blocks but presynaptic acetylcholine release. So this acetylcholine release stop blocks its acetylcholine release, and this leads to decrease of muscle tone and anisocoria. Okay, if you have any doubts you can put a comment. Okay, I will try to resolve it. Then I think this should be the last one. Okay, a 72-year-old patient after operation due to cholecystectomy was prescribed gentamicin and cephalothin. Due to fever on 10 days, there was an increase in creatinine up to 300 train. Wow, 310. BP 130 by 80. Daily quantity of the urine is 1200 normal. Urine test without pathology. Okay, ultrasound the size of kidneys is normal. Okay, so all these things are normal. So hepatorenal unequal infusion of liquid now. Cortical necrosis. So if there is necrosis, there would be size problem. So no. Then acute glomerulonephritis. I have said that glomerulonephritis symptoms I have told you already. There will be high BP. Okay, and bilateral involvement and proteinuria like this. Hepatorenal syndrome. No problem in liver. So as you saw, there is some nephrotoxicity. Okay, and some drugs do nephrotoxicity. These are some antibiotics. Antibiotics. What are the antibiotics? Aminoglycosides mainly. These aminoglycosides like gentamicin, kanamycin. Okay, these cause nephrotoxicity. Nephrotoxic. Also, these are ototoxic. Okay, so cephalothin, penicillin. This rarely cause nephrotoxicity. Mainly gentamicin. It is a drug class of aminoglycosides antibiotic which causes nephrotoxicity. So I think this is enough for this video. And if you guys have any question, please let me know. Okay, you can email me or you can put a comment. Just if you need to clear any topic also, you can post it in the comment section. I will try to cover it. Okay, thank you. Bye bye. See you in next video.